Module 6. In this module, we're going to turn our attention towards cardiodynamics. Cardiodynamics includes all of the factors that are going to affect something called cardiac output. Cardiac output is defined as the amount of blood ejected from your left ventricle into the aorta each minute. However, cardiac output really is the amount of blood ejected from each ventricle per minute, because what's happening on the right side of the heart is happening on the left side of the heart at the exact same time. So your two ventricles are ejecting similar amounts of blood during every cardiac cycle. However, most books will define cardiac output based off the left ventricle because your aorta is sending blood throughout the systemic circuit, and the systemic circuit is more easily accessed and measured. Now, cardiac output is important because it's an indicator of the amount of blood flow passing through your tissues per minute. So, if you actually were to measure flow rates through your tissues, your entire cardiac output does flow through every tissue per minute. That's how rapid blood is moving throughout the body. So whatever happens to cardiac output is going to have a direct impact on how much blood is flowing through all of your body tissues. Now, cardiac output is influenced. It can be changed or affected by factors called stroke volume and heart rate. Now, stroke volume you were just initiated to. It's the volume of blood ejected from your ventricles in one cardiac cycle. We now are going to factor in heart rate, which is the number of cardiac cycles per minute. So if you think about the definition of cardiac output, it's the volume of blood ejected per minute. So we're going to take our stroke volume, which is how much is ejected in one cycle, and then multiply it by heart rate, your number of cycles per minute. What this means is that if you change either stroke volume or heart rate, you're going to change your cardiac output. So if you, by some chance, increase your stroke volume or increase your heart rate, you're going to have an increase in cardiac output as well. And you will find, as you learn more about the body this semester, that cardiac output does vary with activity. For example, if you are undergoing very vigorous activity, you're going to have a really great increase in cardiac output. Now, thinking about that does mean that you are going to have what is called a cardiac reserve. The cardiac reserve is the difference between your maximum cardiac output, which is what you would have with very vigorous physical activity, and your resting cardiac output. So you need to have this reserve so that if you increase your output, you have what you need in order to support that increase. Now, since cardiac output is impacted by stroke volume and heart rate, we're going to need to first discuss what can influence your heart rate, and then we need to talk about what can influence your stroke volume. Now, what makes this particular section of the chapter challenging is that students will study, here's what's going to affect heart rate, and they'll study that as if anything's changing, it could be heart rate. And then students will compartmentalize stroke volume as something separate. And you have to kind of keep in mind that what's changing heart rate is most likely also influencing stroke volume at the exact same time. So these two factors are changing simultaneously. So even though we discuss them separately, know that they are happening at the same time. So we're going to start with heart rate. And when you start thinking about affecting heart rate, you can either speed it up or slow it down. So you are going to need positive chronotropic agents, which are going to raise your heart rate, and negative chronotropic agents, which are going to lower your heart rate. Now, when you start thinking about what these agents might be, these agents could be signals from the nervous system, they could be chemicals such as hormones or ions. There are even other factors outside of the nervous system and chemical signals that can also act as chronotropic agents. So we're going to start with your nervous system and look at how it is affecting your heart rate. Now, the chronotropic effects that are coming from the nervous system are going to arise through the autonomic nervous system. Now, the actual center for this nervous control is found in the medulla oblongata, in those little cardiac centers, which are part of the cardiovascular centers. So this is where you have to go back to A&P 1. You need to go back into your medulla oblongata notes from chapter 14. In the medulla oblongata, you have cardiovascular centers that help to regulate things like blood pressure and heart rate. In that cardiovascular center, you have small little subcenters that are called cardiac centers, and those are the ones that are going to govern your heart rate changes. Now, because the medulla oblongata is locked up inside the brain, it can't just leave and walk down to the heart and talk to it and tell it what to do. Also, the medulla oblongata can't travel throughout the body looking at different changes that are occurring to figure out, do we need to change heart rate? So the cardiac centers are going to have to get input so that they know what's happening in the body and then make a decision on what to do. So your cardiac centers are going to get information from proprioceptors. And you learned in A&P 1 that propriocenters monitor joint and limb position. So the proprioceptors are giving the cardiac centers information about changes in physical activity. Because if your physical activity is increasing, you're going to have more stimulation of the proprioceptors. You're going to have more changes in joint position, more changes in limb position. You're also going to get information from chemoreceptors. Chemoreceptors monitor blood chemical changes. The chemoreceptors sending information to the cardiac centers specifically are sending information about changes in pH, changes in carbon dioxide level, and changes in oxygen level. So we're getting information here. And changes in your respiratory gases and pH are indicating changes in activity. Because if you are more active, your oxygen is going to be a little bit lower because your cells are using more oxygen for ATP. But your CO2 levels will be a little bit higher because your cells are more active and are producing more waste gas. You'll also learn later in the semester that it's the carbon dioxide that actually can lower your pH. So a drop in pH is also indicating higher levels of waste gas. Baroreceptors are going to monitor stretching in organs. Now, dealing with the cardiovascular system, we are looking at baroreceptors in your major arteries. And changes in blood pressure change the stretching on the walls of your arteries. So your baroreceptors in your major arteries are being stimulated by changes in stretching due to changes in pressure, and that's getting sent up to the cardiac center. You also have information from your cerebral cortex, your limbic system, your hypothalamus, those more higher brain areas, And it's going to allow sensory and emotional stimuli to also alter your heart rate. So your little cardiac centers are getting a lot of information. And based on this information, they're going to activate either your sympathetic or parasympathetic divisions. Now, if sympathetic innervation is what is elicited through the cardiac center of your medulla oblongata, that sympathetic innervation is going to be sent down to the heart through cardiac nerves, and this innervation is going to have a cardiostimulatory effect, meaning we're going to stimulate more cardiac cycles. We're going to increase heart rate. Now, this cardiostimulatory effect is caused by the release of norepinephrine by the cardiac nerves. The cardiac nerves are going to deliver that norepinephrine to the sinoatrial node. Now, the norepinephrine is going to activate the cyclic AMP second messenger system in the cells of the sinoatrial node. The result of the cyclic AMP second messenger system is the opening of calcium channels in the plasma membrane. Now, if you open calcium channels in the plasma membrane, you're going to allow calcium to flow from the extracellular fluid into the cell. So we're going to start having a huge amount of calcium inflow. And remember, calcium is a positively charged ion. So we're going to have all of these positive calciums flowing inward, which is going to accelerate the depolarization of the SA node and accelerate the contraction of the cardiac muscle cells. In addition, cyclic AMP then also accelerates the uptake of calcium by the sarcoplasmic reticulum, which causes the cardiac muscle fibers to also relax more quickly. So now think about the combination of these two effects. This calcium inflow is going to make your SA node fire faster, which makes the muscle contract faster, but also relax faster. Now, if you're trying to increase heart rate, you want to make sure that you can do the full cardiac cycle as quickly as possible so that you can do more cardiac cycles per minute, which means you have to both contract and relax fast. And this effect of norepinephrine causing the activation of the cyclic AMP second messenger system actually accomplishes both goals. It accelerates both contraction and relaxation so that you can have a faster heart rate. Now, if a parasympathetic innervation is elicited through the cardiac centers of the medulla oblongata, this parasympathetic innervation is going to arrive at your sinoatrial node through what are called vagus nerves. And the signal from the vagus nerves is going to have a cardioinhibitory effect. Now, if you think cardioinhibitory, this effect is going to inhibit the production of cardiac cycles, so it's going to slow your heart rate. Now, the actual effect is created by the neurotransmitter that's going to be released at the sinoatrial node, and that is acetylcholine. Now, what acetylcholine will do is it will open potassium channels in the plasma membrane of the cells of the sinoatrial node. And if you open up those potassium channels, you're going to allow positive potassium ions to actually flow out of the cells into the extracellular fluid. And this loss of positive charge is going to cause the cells of the sinoatrial node to become hyperpolarized, meaning they're going to be more negative than they are at their temporary resting membrane potential. And if they're hyperpolarized, they're going to fire off action potentials less frequently, which is going to decrease your heart rate. Now, if you compare the action of the sympathetic and parasympathetic divisions on heart rate, the parasympathetic effect is actually faster acting because the effect is right on the plasma membrane. The sympathetic effect, you have to first activate the cyclic AMP mechanism, then you get your effect. So the parasympathetic effect can be seen a lot more quickly because it's a little bit more direct. There are also some other mechanisms for affecting heart rate. You do have what is called an atrial reflex, and the atrial reflex involves what is called venous return. Venous return is the volume of blood that returns to the atria during a cardiac cycle. So while those atria are in their diastole, it's how much blood they fill with. And if you increase venous return, you're going to increase the amount of blood filling your atria, which is actually going to increase their stretch. If you have more blood returning, your atria hold more blood, they're going to stretch. And that increase in stretch is detected by baroreceptors. And those baroreceptors will send that information up to your cardiac centers, and they will respond with an increase in sympathetic activity, leading to an increase in heart rate through the mechanism we just discussed. However, venous return does have another effect on heart rate in addition to being part of this atrial reflex. If you think about venous return and you've got this increase in volume, you'd have this increase in volume inside the right atrium, correct? Well, if the whole right atrium is stretching, wouldn't it mean that your sinoatrial node is stretching also? So if you have an increase in venous return, you're going to have an increase in the stretching of your sinoatrial node. And that little sinoatrial node is really sensitive. And if you stretch it, it will respond. And it will respond by increasing its rate of depolarization. So your sinoatrial node will start forming more action potentials per minute. So it's going to start firing faster. And the more action potentials you create, the more cardiac cycles you initiate, leading to an increase in heart rate. Now, there are chemicals that also can have chronotropic effects on heart rate. Norepinephrine and epinephrine are released as hormones from your adrenal gland. Now, when we get to the endocrine system, you will learn what part of the endocrine gland is producing it, how it's triggered to produce it, in detail that I'm sure you never wanted to know. For right now, you need to know that these two hormones are going to have the exact same effect as the norepinephrine neurotransmitter from the sympathetic division. Thyroid hormone also has the ability to increase heart rate and contractility, however, through a much different mechanism. Thyroid hormone actually increases the number of adrenergic receptors in the sinoatrial node. Now, recall from AMP1 in the autonomic nervous system chapter that adrenergic receptors are going to bind norepinephrine and epinephrine. So thyroid hormone is going to increase the number of receptors for epinephrine and norepinephrine. And what that's going to do is it's going to make your sinoatrial node much more sensitive to sympathetic innervation. So much so that hyperthyroidism, now hyper always means too much. So hyperthyroidism is an abnormally high level of thyroid hormone. And one clinical symptom of hyperthyroidism is tachycardia. Because you have so much thyroid hormone, you're making your sinoatrial node overly sensitive to norepinephrine, and just a little bit of norepinephrine is going to have a very significant impact on heart rate, and it's going to lead to tachycardia. Nicotine also affects heart rate. Nicotine can accelerate your heart rate by stimulating catecholamine secretion. The catecholamines are epinephrine and norepinephrine. So it's going to actually accelerate heart rate by stimulating your adrenal gland to release more epinephrine and norepinephrine into your blood, and then that's going to elevate heart rate. Caffeine inhibits cyclic AMP breakdown. So by inhibiting the breakdown of cyclic AMP, you actually can prolong your sympathetic effect. So it's going to allow you to maintain that higher heart rate through the sympathetic division by keeping the cyclic AMP around a lot longer. Now, potassium ions, depending on how you change it, you can have some really profound effects on heart rate. For example, hyperkalemia. Hyperkalemia is when you have pretty much a complete reversal of your potassium gradient. Your potassium ions are now higher in your extracellular fluid and lower in your intracellular fluid. And if potassium's high on the outside, and you guys learned in A&P1, the plasma membrane is very permeable to potassium leakage, your potassium ions are going to start leaking in. And you're going to have all of those positive potassium ions leaking inward, and it's going to keep your membrane depolarized. So you'll get this great action potential, boom, you'll depolarize. And the problem is that you stay there. Because after you depolarize, even in cardiac muscle, you'd go through plateau, but then you have to be able to repolarize. And to repolarize, to return to rest, potassium ions have to move from inside the cell to outside the cell and carry that positive electrical charge out of the cell so that it can become negative again. The only thing is that if you change your potassium gradient in hyperkalemia, potassium will only flow inward. So the potassium will make you depolarize, completely and totally block your ability to repolarize ever again. And this effectively stops the heart. You will kill someone. If you have ever heard of angel of death killers, usually what they inject the patient with is potassium. And they induce hyperkalemia, which effectively stops the heart. Lethal injection also involves the injection of potassium to stop the heart. Bayfront Medical almost killed me with hyperkalemia. When I was in the hospital with pneumonia, my daughter was at All Children's with pneumonia, they gave me too many IV fluids because my blood pressure, in their opinion, was too low. Well, they put in 6 liters of saline over the course of 3 hours. I gained 10 pounds in water weight in just a few hours. So they diluted out my ions and got very nervous that my potassium ions were too low. So they started giving me IV potassium, and they gave me potassium pills to take at home to manage to keep my potassium levels up. Well, luckily I teach this course, and I knew that they were wrong, because the moment that I came home and actually could, not to share too much information, urinate out all of the extra fluid volume, my potassium ions were completely normal on their own. If I had taken those potassium pills the way they had directed, I would have induced hyperkalemia and I would have died. So you have to be really careful with any type of potassium injection because you do not want to reverse this potassium gradient accidentally. Now, if you can have hyperkalemia, you could have hypokalemia. Now in hypokalemia, you're going to have an abnormally low level of potassium in your extracellular fluid. Now I know we have already described that the extracellular fluid has low levels of potassium. Imagine if they are even lower than normal. So we've got very, 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 very little potassium. That means your potassium gradient is actually steeper. If you compare the concentration of potassium inside the cell to the now abnormally low on the outside, that really steep gradient is actually going to increase your rate of potassium diffusion out of that cell. So your cells are going to start losing by diffusion more potassium, and that's actually going to end up hyperpolarizing your plasma membrane. At rest, your membrane is going to be more negative than it was before because you've now shifted your potassium balance. And if the membrane is hyperpolarized, it's going to be a lot harder to stimulate. So hypokalemia also decreases your heart rate. And if that hyperpolarization becomes too significant, you might not be able to stimulate the heart to depolarize. So you could effectively stop the heart as well with hypokalemia. Changes in calcium in the extracellular fluid also have impact on heart rate. However, the imbalances in calcium are relatively rare, so they're really hard to achieve. And the major effect of the calcium imbalance is ultimately on contractility, but there is an impact on heart rate, although minor, which is why we're mentioning it here. Now, hypercalcemia, meaning you have an elevated concentration of calcium in the extracellular fluid, actually decreases your heart rate. The higher concentration of calcium actually blocks the voltage-gated sodium channels. It actually makes it a lot harder for sodium to flow through the channel into the cell. And if you decrease that sodium permeability, you can inhibit depolarization, which again is going to decrease your heart rate. Hypocalcemia, meaning an abnormally low calcium concentration in your extracellular fluid, will allow greater sodium permeability. So sodium's going to have a much easier time coming in. Your cells are going to be overly excitable because they will depolarize a lot more rapidly, and you get that nice elevation in heart rate. There are other factors that can affect heart rate. Age is one. You actually have a decrease in heart rate with an increase in age. So children have much higher resting heart rates than adults just because of the age difference. One of the things that freaked me out the most when I was pregnant with my daughter Melanie is I was listening to her heartbeat at the office, and I saw on the monitor that it was 140 beats per minute. And I completely and totally freaked out because, average resting heart rates, high 60s, low 70s, somewhere in there. And, my OB said, no, 140 is quite normal. It's average, for a developing fetus. Now, her resting heart rate now is in the mid-80s, and she is very physically fit. She swims competitively, so really good endurance exercise. It's just that she's young. So as you get older, your average resting heart rate just declines. So that's something you have to factor in when you're treating patients. If you're treating children and adults, you need to understand what normal is so that you can determine if what you see is not normal. Gender plays a role, not factoring in physical fitness in any way, just going based on gender. Females have higher resting heart rates than males. Right? So there is a gender difference. They don't exactly know why there's that gender difference, and I haven't found any literature to clarify the why either. So, but they have noticed that between males and females. Physical fitness, huge impact on heart rate. If you increase your physical fitness. Now, when you're thinking about this, you need to think cardiovascular fitness. So exercising with those endurance activities. So long distance running or jogging, getting on the elliptical. This is not weight training. Okay, this is not weight training. Weight training does not improve cardiovascular fitness. So if you're doing these endurance type activities on a regular basis, you'll actually see a decrease in your heart rate over time. In fact, most people who are very physically fit with the endurance training, they have bradycardia naturally at rest. And it is a huge benefit because the slower your heart is, with the cardiovascular training, it makes the heart more efficient. Now, I know you're probably wondering why that is, and I will clarify that why when we talk about stroke volume and the factors that affect it. With regards to body temperature, I know my A&P1 students were taught to know if you heat it up, you speed it up, and if you cool it down, you slow it down, to kind of remember the effects of temperature on diffusion. Well, that holds here too. With regards to body temperature, altering body temp will alter your sinoatrial node firing rate. So if you increase body temperature, you will increase the rate of sinoatrial node firing, which increases your heart rate. If you decrease your body temperature, you will decrease the rate of your sinoatrial node firing, and you will have a decrease in heart rate. So if you ever move up north and you're in a hospital ER and someone comes in with severe hypothermia means that your body has been exposed to the cold for so long that your average body temperature has dropped. People have come in with 86 degrees Fahrenheit. I mean, like severe drop in body temperature. And, heart rate so slow it's barely detectable. And people have come back from that. Now, yes, the heart rate is so slow it's barely detectable. Blood flow then would be equally as slow. However, your metabolism overall is slow. The entire body has been cooled. So the decrease in oxygen delivery because of the slow heart rate and slow blood flow actually doesn't have that much of an impact on the survivability of your tissues because their oxygen needs have declined. All right, so now that I have completely overwhelmed you with all of these factors that affect heart rate, let me now overwhelm you with the factors that affect stroke volume. Now, what you have to remember about stroke volume is that a healthy heart will pump out the blood that entered its chambers during the previous diastole. So the general rule of thumb is that if more blood returns during diastole, you will eject more during the next systole. So venous return is going to have a huge impact on stroke volume. Which leads us to the first factor that affects stroke volume, and that's something called preload. Now, preload is defined as the degree of stretch on your ventricle during diastole. And we've already talked about that it's blood volume in a chamber that causes stretch. So if you're looking at the degree of stretch on your ventricle during its diastole, its fill time, you're looking at your end diastolic volume. So preload is always proportional to your end diastolic volume. So if you increase end diastolic volume, you will increase preload. If you decrease end diastolic volume, you will decrease your preload. Now, the effective preload on stroke volume is explained through the Frank-Starling law of heart. Now, according to this law, the more blood that fills your ventricle, the greater the ventricle is stretched. We've already talked about that. What this law then explains is that the more a ventricle stretches, the greater its contraction force will be. So the more you stretch your ventricles, the greater their contraction force. So now let's put that together with what we already know. So if we increase end diastolic volume, we increase the stretch on our ventricles. If we increase the stretch on our ventricles, we increase their contraction force. Now, if we increase contraction force, we increase the volume that we can eject. We increase our stroke volume. Now, if we have less blood filling the ventricle, then we will have less stretch on the ventricle. Less stretch means a decrease in ventricular contraction force. If you contract with less force, you will have a decrease in your stroke volume. Remember, to eject blood from the heart, you have to have enough force from the ventricles. So their force determines how much leaves. Now, there are factors that will affect your end diastolic volume. For example, the duration of your ventricular diastole. Remember, ventricular diastole is when your ventricles are relaxed and filling. So if you increase your diastole time, if you increase your fill time, wouldn't you increase your end diastolic volume? And if you decrease your fill time, wouldn't you decrease your end diastolic volume? Now, what potentially could alter fill time? Well, heart rate. If you have an elevated heart rate, wouldn't that mean you have less time in diastole? If you have less time in diastole with an elevated heart rate, you're going to increase your end diastolic volume, which is going to decrease your stroke volume. So it is possible for you to increase your heart rate to tachycardia. And tachycardia decreases your fill time so much that your stroke volume decreases. You don't have enough time to actually fill with blood. However, if you can slow the heart down, if you decrease your heart rate, your ventricles have longer fill times. They're in diastole for a longer period of time. If their fill time is longer, they can have a greater end diastolic volume, meaning that even with the slower heart rate, when they contract, they'll contract with greater force and actually eject a greater volume of blood. This is what happens in physically fit, endurance-trained athletes. They have bradycardia, so they do fewer cardiac cycles per minute, But because of all the other cardiovascular changes their body has undergone, they have a longer fill time and more blood coming into those little ventricles, and when they contract, they have a greater stroke volume. So they can contract less and still eject more. So the physical fitness, huge benefit. Venous return also is going to impact your end diastolic volume. Because remember, venous return is the amount of blood returning to your atria. Well, doesn't the blood in the atria end up in your ventricles? So if you have more blood entering your atria, so you have an increase in venous return, wouldn't that end up increasing your end diastolic volume? And if you have a decrease in venous return, wouldn't that lead to a decrease in your end diastolic volume? Now, venous return is influenced by a lot of different factors. It's affected by overall blood volume, peripheral circulation, skeletal muscle activity, many other factors. And we'll talk a lot more about these factors and how they exert these effects on venous return in our blood vessel chapter. Now, before leaving this slide, I do want to mention one other thing that the Frank-Starling law accounts for. The Frank-Starling law also equalizes the output between the right and left ventricles. And this is important because it's going to guarantee that you have the same volume of blood flowing through both your systemic and pulmonary circuits. So not only does this law regulate stroke volume with every cardiac cycle, but it's keeping your circuits in balance. We don't go into the specifics of how it keeps the circuits in balance, but if you're interested, feel free to ask during lab. I'll be happy to fill you in. Another factor that affects stroke volume is contractility. Contractility is the strength of contraction at any given preload. So when you start thinking about contractility, we're looking at other things that might affect the strength of contraction in addition to preload. So we're looking at other things aside from the stretch due to blood volume. And when you start looking a little bit broader, there are some chemical agents called positive inotropic agents that will increase your contractility. So they have the ability to increase the strength at which you contract. And most of your positive inotropic agents are agents that increase calcium entry into the cardiac muscle cells. Because remember plateau. And plateau was allowing you to bring calcium into the cell, and that by bringing in that calcium, you allowed the sarcoplasmic reticulum to release more calcium and intensify your contraction. So anything that's going to let even more calcium into your cardiac muscle cell, definitely going to boost your contractility. So some examples of these positive inotropic agents are things like hypercalcemia. Now, yes, hypercalcemia decreased heart rate, but it didn't stop the heart. So when your cardiac muscle cells are stimulated, okay, your sinoatrial node does send out an action potential. Those little cardiac muscle cells are going to undergo their action potential. When they hit plateau and you open up those voltage-gated calcium channels, you're going to have a greater influx of calcium, which is going to intensify the effects on the sarcoplasmic reticulum. It will release more calcium and your contraction force is going to be enormous. Sympathetic stimulation increases heart rate, but it also increases contractility. It does impact the cardiac muscle cells. The hormones epinephrine and norepinephrine do impact more than just the sinoatrial node. They will increase contractility. Glucagon, which is a hormone released from the pancreas that helps to regulate blood glucose, does also impact cardiac muscle cells and increase contractility. Thyroid hormone, we already mentioned its effect on heart rate, but it also will affect contractility as well. Digitalis is a medication that actually increases calcium levels inside the cardiac muscle fibers. So also increasing contractility. Even caffeine will increase your contractility as well. Now, negative inotropic agents are going to do the opposite. Negative inotropic agents are going to decrease your contractility, meaning they're going to decrease the force of contraction. Now, usually these negative inotropic agents create this effect by blocking calcium movement. So they're going to block plateau or depress cardiac metabolism. So they're going to decrease the ability to produce action potentials. So things like acetylcholine. Acetylcholine, it does decrease heart rate. It has a minor, very minor effect on contractility. Hyperkalemia, huge effect. Hyperkalemia, definitely a huge negative effect on contractility. Hypocalcemia is going to have a negative effect on contractility also. Myocardial hypoxia. So hypoxia is a tissue oxygen deficiency. So by having too little oxygen in the myocardium, you're not going to be able to produce the ATP. It's going to block your ability to contract. Myocardial hypercapnia, which is an elevated CO2 level. Myocardial acidosis, which is a more acidic pH. These also are going to depress your cardiac metabolism. With regards to medications, there are medications that are referred to as calcium channel blockers. So these are chemicals that, if ingested, can find the voltage-gated calcium channels and actually block them so that you can't open them, you're going to lose your plateau. And some drugs for hypertension. Now, hypertension is high blood pressure, and some drugs for hypertension block sympathetic stimulation. And if you block sympathetic stimulation, you're going to have a lower heart rate, but also lower contractility. The last factor affecting stroke volume is called afterload. Afterload is the sum of all the forces a ventricle must overcome before it can eject blood. Now remember from the discussion on the cardiac cycle that prior to ventricular systole, the pressure within the aorta is 80 millimeters of mercury, and the pressure within the pulmonary trunk is 10 millimeters of mercury. And that in order to eject blood and open those semilunar valves, your ventricles must create more pressure than in those arteries. So your left ventricle has to be able to get above 80 millimeters of mercury, and your right ventricle has to get above 10 millimeters of mercury. And not just by a little bit. You have to be able to create enough pressure that you cannot just open the valve, but you have to be able to hold it open long enough to eject your full stroke volume. So it's not just a matter of opening the door for blood to leave, but it's also holding the door open long enough to eject your full stroke volume. Now, if your afterload increases, if it's going to be harder for you to open the door and to hold the door open, you're going to see a decrease in your stroke volume. Right? So again, think of it as you've got a door and you're the ventricle and you're pushing on the door and you're trying to get it to open, but you have a friend on the other side offering resistance. So it's you and one friend. And you can create enough pressure to push the door and your friend so that people can get out of your house. What if you put 3 friends on the other side of that door? And now it's you pushing on your side, but 3 friends pushing on the other. Wouldn't it be a lot harder to open the door? And if you manage to open the door, wouldn't it be a lot harder to keep the door open with those 3 friends still pushing on it? That is an increase in afterload. Your friends are increasing that afterload is going to make it a lot harder for you to open the door and hold it open. Now, there are factors that will affect your afterload. Blood pressure in the aorta and the pulmonary trunk, huge factors affecting afterload. Because remember, in a healthy person, the aorta is about 80 millimeters of mercury just prior to ventricular systole. Pulmonary trunk is 10. But what if you have hypertension and the pressure in your aorta is now not 80 millimeters of mercury, but it's 110? Isn't it going to be a lot harder to open the semilunar valve? I mean, think about it. Instead of the semilunar valve opening the moment the left ventricle gets to 81, wouldn't your left ventricle have to build up and build up and build up pressure until it gets to 111? And then the semilunar valve will open. However, the peak pressure in that chamber is 120. And it doesn't stay there for long because doesn't your ventricle have to then relax? So it's going to take a lot longer to open the door. And then once the door is open, you're not going to be able to hold it open very long. That's all going to contribute to a huge decrease in your stroke volume. Arterial circulation, going to have a huge impact. With regards to arterial circulation, we're going to learn a lot more about it in our blood vessel chapter, but changes in arterial circulation can actually increase blood pressure. And again, if you have an increase in arterial blood pressure, it's going to decrease or increase your afterload and decrease your stroke volume. You also have to factor in the health of the myocardium itself, because in a healthy heart, your left ventricle can reach a peak pressure of 120 millimeters of mercury, allowing you to open up the aortic valve once you get above 80 millimeters of mercury and hold that valve open so that you can get that full stroke volume out. What if your patient had a heart attack? Heart attacks are biologically called myocardial infarctions. In a heart attack, you actually have death of cardiac muscle. So what if the heart attack occurred in the wall of your left ventricle and you damaged myocardium? Can the left ventricle, when it contracts, reach that nice, healthy peak of 120 millimeters of mercury? And the answer is no. If the muscle has been damaged, it can't create the same amount of force as it did before. Maybe it can only reach a peak force of 100 millimeters of mercury. So yes, it could still open the semilunar valve, but can it hold that valve open as long as it used to? And the answer is no. In fact, what if the heart attack was so severe that your left ventricle now, peak pressure, only gets to 75 millimeters of mercury? Will it even stand a chance at opening the semilunar valve? And the answer is no. So anything that increases afterload, anything that's going to make it harder for the ventricle to open the semilunar valve, anything that's going to make it harder for the ventricle to keep that valve open for as long as it needs to be open is going to have a decrease, is going to cause a decrease in your stroke volume.